Hey everyone, in this part of our blood chapter, we're going to get into the leukocytes, which are the white blood cells, and then we'll talk a little bit about blood typing and also this process known as hemostasis. Okay, the white blood cells are different than the red blood cells in that there are several main types. There was only one main type that we looked at for the red blood cells. But for the white blood cells, there's 5 kinds. There's the neutrophils, the eosinophils, the basophils, the monocytes, and the lymphocytes. And there's a clever mnemonic that you can use to help you remember their relative abundance in the human body. So the age-old mnemonic is this: never let monkeys eat bananas. That will tell you the order that they are present in abundance. So N stands for neutrophils, L stands for lymphocytes, M stands for monocytes, E stands for eosinophils, B stands for bananas. In other words, the basophils, B for basophil, are the most rare, and N for neutrophils are the most abundant. Okay, these will travel in the blood usually just for a short while, and then they'll take up residence in the tissues of the body. So that's what makes them different than the red blood cells. The red blood cells, they will stay in the blood, and the white blood cells actually can get out of the blood vessels and travel around in the body, which is pretty fascinating. They migrate through the different connective tissues that are found inside the body, and the way that they find their way around is through these processes known as chemotaxis and diapedesis. So here's a picture that illustrates chemotaxis. Chemotaxis is a way that cells can recognize a place that they're being recruited, and basically how it works is they follow increasing concentration gradients of some sort of chemical attractant. So when pathogens, this is showing you, let's say, a cut, and pathogens get in and they start causing tissue damage, what that can do is it can release these different chemicals, and those chemicals at the source of the infection will be most concentrated because that's where they're being made and released. But as they travel away from the site of the infection, they become least concentrated or less concentrated. And so a cell can actually detect and sense the concentration of those chemoattractants and find its way up towards the place of higher and greater concentration, and eventually will ultimately lead to the site of infection. So here's a couple of cells, eosinophils, monocytes, neutrophils, traveling in a blood vessel. They're coming by a site of infection, and so that would be telling the cell, if they're encountering any of these molecules, that's signaling to them that there's an infection right outside the blood vessel, and it's time to eject out of the blood vessel and enter into the tissues. Okay, so what they'll do is, it's a pretty elaborate mechanism. They'll anchor into the endothelial wall of the blood vessel, and then they'll slow themselves. They'll usually do like a little spinning, rolling maneuver here as they coat themselves with a sticky protein that helps them anchor to the surface of the blood vessel and not be carried away with the rest of the red blood cells. And then they can actually, and it's totally fascinating, this little cell can sneak its way in between those cells that line and make up the wall of the blood vessel. And then they can sneak out of the blood vessel and in now to the underlying connective tissues where the site of infection is. Chemotaxis is the ability for them to follow a chemical concentration gradient to the site of an infection. Chemotaxis is a general word to describe that property, even when it's not talking about infections. It's just if a cell needs to get from one place to the next, and it uses sort of the chemical gradient as a honing beacon, it's called chemotaxis. But diapedesis specifically is the process by which the cells move through the endothelial walls. Okay, a little bit here about the histology of how these look. This might be something that you have to do on an exam or a lab practical. So let's practice a little bit here. I have all the different types of white blood cells here. and I'll show you a little bit about how you recognize them. Okay, this one and this one, these are neutrophils, and when I'm identifying these, I usually look at the size of the red blood cell and use them as sort of a measuring stick. Usually a neutrophil is about 2 red blood cells across, so it's about 14 or 15 microns in diameter. And neutrophils have sort of this multilobular dark staining body in here. If we look at some of these other cells, this cell right here, this is a lymphocyte, and it's a little smaller than the neutrophil. You know, if you can sort of see that, the cross section here is a little bit less than maybe the cross section of a neutrophil, not by much, but a little bit. But what's characteristic of these is that the nucleus takes up much of the cell, and in fact, this is sort of a generous perspective. Usually the cell is only about like this, and there's just a small sliver of cytoplasm visible. This dark staining nucleus takes the whole volume of the cell, save a small sliver on the side, usually. That'd be different than a neutrophil. Even though they're similar size, the neutrophil is going to have a multilobate, looking nucleus, and in this one, it takes up most of the whole cell. Okay, this one over here is an eosinophil, and note the red color. It's quite a bit more red than the neutrophil. If I ever asked you about an eosinophil, I would usually include a neutrophil in the picture so that you could at least compare and see that it's red, more red. Another feature of eosinophils, they generally have 2 lobes here to this dark staining body with a bridge that connects them, and almost looks like an old school telephone receiver. Sometimes they can look a little bit more like this, where it's more of a C shape, but in either case, it will be that more of a red hue that's very characteristic of an eosinophil. The basophil is shown here, and you're going to see these dark splotching granules of whatever they are. I don't know exactly what they contain, but they stain dark, and they're found throughout the whole cell, even in the places that are just mostly cytoplasm of the cell, like right here, you'll still see these dark staining granules. And this is a fairly large cell. This is just as big as the eosinophil or the neutrophil. These are the most rare, very difficult to find one on a normal blood slide. Less than 1% of all leukocytes are basophils. And then the last one that you see here is the monocyte. And monocytes are identified by the fact that they're quite large, usually like, about probably closer to 20 microns in their diameter, so closer to 3 red blood cells in diameter, if you're using the red blood cells as a measuring stick. And then the nucleus is going to be this big kidney bean shape, usually. So the size and then the kidney bean shape usually are the give away that that is a monocyte. And then lastly, I have this little dark purple thing here. This is actually a platelet. We talked about those earlier. They're just cytoplasmic fragments. They're not actually cells, but they're used for blood clotting. And you'll see platelets scattered throughout the plasma. The plasma would be all of this fluid that exists in between the red blood cells. The platelets are very small. They'd be smaller than, like, let's say, the size of a red blood cell. Okay, so you'll want to maybe be able to do that, and you can come back to this lecture and quiz yourself on those until you've got them right. But if I asked you on an exam or something, I would pick a cell that looks fairly similar to the ones that you're seeing here, so at least you would have a good idea of how to identify it. Okay, now you can do this count actually, and when I was at a hospital in Ecuador, I walked into a lab once and saw a bunch of people on these clickers, and they're literally looking at blood slides, clicking and counting the cells, scanning up and down through the slide and tallying up how many neutrophils they see, how many lymphocytes they see, how many eosinophils they see. This is called a complete blood count. It's a very standard assay that's requested at a follow-up, at a physical or any type of doctor's appointment where they're doing a blood draw. Generally, they're going to order a complete blood count. This is a sample of one, and it will literally tell you what is the percentage of the neutrophils, what is the percentage of the lymphocytes, the monocytes, the eosinophils, the basophils. This will tell you percentages, or it could tell you absolute values, how many millions per microliter, or I guess that wouldn't be millions, that would be how many thousands per microliter. So the actual number of them. Other things that you can see on a differential count would be, it will tell you the amount of hemoglobin, and that is in grams per deciliter, how much hemoglobin, grams per deciliter. It'll tell you the hematocrit, what percentage of the whole volume what percentage of the whole volume is red blood cells. And here we're showing 31% of all of the whole blood is made out of the red blood cells, and that's actually low. You've got the normal values here, and it will tell you, what's low, what's high, what's low, what's high. Some of these other ones, this one, MCV, I think it stands for the mean corpuscular volume or something like that. It's basically how big are the cells, not necessarily just how many of them, but how big are they. There's some conditions where there can be abnormally large cells. But this is a really important test because you can tell a lot about somebody's health just by these, okay? An increase in neutrophils would tell you that you're probably having some sort of infection of some kind, some sort of infection somewhere in the body. That'd also be true of the lymphocytes. If you have an increase in the eosinophils, it usually is the signal of an infection, or an invasion of like a larger parasite, like a larger protozoan, like a blood fluke or like a pinworm or some sort of parasitic animal. Also, eosinophils will have a higher count when you're having an allergic reaction to something. And then basophils, these are usually you have a higher number of these when they're trying to reduce inflammation. That's one of the jobs of basophils, is to reduce inflammation. So, interesting assay there, clinically relevant, very common. Any type of blood work that's done is likely going to come with usually a CBC. And then other things that people would assess in the blood, they might assess for like different hormones, thyroid hormone, T3, T4, some of those other hormones are pretty common to assess in the blood. Okay, we're going to talk now about clotting. So this isn't where the platelets come into play. Again, platelets aren't cells, but they are fragments of cells that are found strewn about in the plasma. And when you get a cut, your blood vessels know how to stop the loss of fluid from that vessel. And this is a very valuable thing. If it wasn't the case, if you couldn't undergo hemostasis, anytime you got a small cut, it would just keep bleeding and bleeding and bleeding and never stop, ever. And there are disorders, genetic disorders, that can cause that. One of them is called hemophilia. But fortunately for you, if everything's normal, you form blood clots, and that saves you from that constant loss of fluid. Well, the phases of hemostasis are the following. There's the vascular spasm, the platelet plug formation, and coagulation. And here's a picture of them. And just generally, you don't have to know this to any intense level of detail, but basically what happens is the first thing is the vascular spasm. Vascular means a blood vessel. Spasm means contraction of the muscle. So when you get a cut, and the blood, let's say you get a cut across your finger, you might have a blood vessel that's cut. And the first thing it's going to do is the smooth muscle in the walls of that blood vessel, they're going to contract down, and they're going to squeeze down the vessel to sort of taper it off and seal it as best as possible. It's not going to be a perfect seal, but it will seal to some extent the vessel. And that's going to be then the bottleneck where the blood clot gets formed. The next phase then is the platelet plug formation, and that is what's going to happen here is that there is going to be different chemicals that are released that cause the platelets to get sticky, and they get spiky, and then they start sticking to one another. They normally don't really stick to anything, or they shouldn't stick to anything. They should just flow nicely in the blood. But when they get exposed to the underlying collagen here in the site of injury, they undergo sort of a chemical reaction and get sticky, and they start sticking in here, almost thinking about it being like clumps of mud or something to plug in this blockage. Now, in and of itself, that's not a very strong patch. That'd be like trying to patch your leaky tire with mud. You know, the mud might kind of get in there and seal the hole and stop the air from getting out, but there's no structure to the mud. There's no structure to the platelet. It's sort of just an aggregate or a glue, so to speak. The real trick here is when these fibrous strands called fibrin, conveniently, get inserted into the patch, and that forms what's called the coagulation of the clotting phase. As soon as you have these strands or the fibers inserting into the platelets, now you have a structural element to the patch. It'd be like, back to the leaky tire and air escaping out of the tire. It'd be like putting mud on there and then putting like a mesh tape or like a fiber in there to make some structure to the patch. It makes it much more strong, much more effective at sealing, and that's what your body does. Now, what's really cool about fibrin is that there is a compound in your blood called fibrinogen, and that is dissolved. It is soluble, meaning it's not present. You wouldn't be able to see it in the fluid. It's just dissolved, almost thinking about dissolving a teaspoon of sugar in water, how it disappears. That's what happens to fibrinogen. But when the conditions are right, and this is a very large, lengthy cascade that I wouldn't ask you to know in this class, but there's a big enzymatic cascade, a chain reaction, so to speak, of chemical reactions that happen to convert fibrinogen into this insoluble strand of fibrin. So fibrin would be, fibrinogen is dissolved in the plasma, fibrin is precipitated out, it's insoluble, and it becomes a structural element. So just think about how cool this is. In your blood, you have this structural component that's just invisible, so to speak. It's dissolved and not present. And then under the right conditions, a whole bunch of chemical reactions can take place to then yield, out of nowhere almost, this structural element, fibrin, to cause the blood clot to form. Okay, now there's a clinical application here, because what can sometimes happen, especially if your blood is pooling somewhere, this can happen like in your legs. If you sit for a very long amount of time and your blood isn't returning, there's not a lot of venous return back to your heart, but your blood is pooling rather in some of the veins of your legs, then what can happen is this clotting response can start to occur. The body can falsely or inaccurately signal a clot. And so then blood cells start sticking together, platelets start sticking together, and the fibrin starts inserting into the platelets, and it forms a clot in your blood vessels when they aren't cut, when they're just normal in your body. And that's called a thrombosis. And if the thrombosis cleaves or becomes detached from its location in the legs, often is where it's found, but it could be found in other places. If the thrombosis, the blood clot, breaks off and now starts traveling through the blood, it can lodge into one of the smaller vessels of your body and actually occlude it and block the blood flow to that organ. So and when that happens, it's called an embolism or an embolus. An embolus would be a thrombosis that has traveled and occluded some vessel somewhere. This can happen in your brain. When it happens in your brain, it's called a stroke or a cerebrovascular accident, CVA. This could happen in your lungs, then it's called a pulmonary embolism. And both of those can be very severe, because it's blocking blood flow to an organ, and that could kill the organ. It could cause a lot of damage to the organ. So some people that have strokes, they can be very severe. They might not ever recover fully from them. Same with a pulmonary embolism. So this is a very severe thing that can happen, and it's actually something that happens quite common, especially as we age. And it might be the case that you have some clots that form in your body and you don't even know about it, what can happen is if a blood clot does form in, let's say, the veins of your leg, it'd be a big, clot that goes all the way down through your leg, through the vessel. Fortunately, we have this process called fibrinolysis. I don't know if I said that right. Fibrinolysis. And this is sort of the reverse of a blood clot. This actually dissolves away the clots. So any clot that's formed in your body has a reverse mode. It can be dissolved away. But if a clot does form, there is sort of a time there where it's of concern, where it could break off. And usually if somebody has a blood clot, they'll put you on like a blood thinner, and that will reduce the risk and help to dissolve they'll put heparin in your not a blood thinner, but they'll give you heparin, which is sort of an anticoagulant. It helps prevent blood clots from forming. And back to my Costa Rica story, when I was in Costa Rica and my heart started going haywire, they determined I had atrial fibrillation. And one of the big concerns with atrial fibrillation, it's a condition where the top two chambers of your heart are no longer pumping rhythmically. And your heart can still work even without the top two chambers. Your heart's got 4 chambers and only needs 2 to work sufficiently. But the top 2 chambers, if they're not working, the blood is pooling in them, and then that can actually start to form a blood clot. And if a blood clot snuck its way into the lungs, or if it snuck its way up into the coronary arteries, that could be a big problem. So they treated me with heparin to prevent the blood clotting from happening. But if a clot should form in your body, it will naturally deteriorate and dissolve through this reverse process, fibrinolysis. Okay, this is really important, blood typing. It might be the case if you're in the clinic that you at some point come across a bag of blood or have to be involved in administering a blood transfusion. And it's important to understand at least the underlying science about why people can receive some bloods but not others. So here's a nice grid that shows blood type scenarios. And on the surface, blood type is really simple. Your blood type really just depends on the type of what's called antigen on the surface of your red blood cell. An antigen, a general word for anything that is characteristic and recognizable and identifiable. And for your blood types, there are several antigens that we talk about. There's A antigens, B antigens, and that forms what's called the ABO blood group. So on the surface, very simple, but it does get pretty complicated quickly. So on the surface, very simple. If you have A antigens on your red blood cell, you have type A blood. It's just all there is to it, okay? If you have a B blood type, you have B antigens on your blood. And guess what antigens you have on your blood if you're AB? You guessed it. You have both A's and B's. This is an example of codominance, where you're expressing 2 dominant phenotypes simultaneously. A and B blood types. A is a dominant allele, B is a dominant allele. So somebody has AB blood type, codominant, 2 dominant alleles expressing A and B antigens. Okay, and then if you don't have any antigens on the surface of your cell, you have an O blood type, and your blood is highly sought after for a reason that I'll explain later. And you wouldn't have any antigens on your surface of your red blood cell. Now, we in an interesting fashion, normally in our bodies, we create antibodies against foreign things. And we don't create those antibodies unless we've actually encountered the foreign things. Like, for example, there might be a virus or a bacterium that doesn't exist today and will exist 3 years from now. And right now, I don't have antibodies to protect myself from it. But when it comes across my body 3 years from now, I will create antibodies against it, and those antibodies will help to keep me healthy. Well, the ABO blood group is a little bit different because you have innately antibodies that bind and destroy against the foreign blood type, even though you've never even maybe seen that blood type before. Those blood cells have never gotten into your body. The AB antibodies are unique in that respect, where you just innately have them. As far as I understand, you innately have them in your immune system, in your blood. So a person with type A blood has in their body anti-B antibodies. And the way that we name antibodies is we name them anti whatever it is that they bind to. So if you had A blood and you have an anti-B antibody, it means you have an antibody that will bind to the B antigen. Because you don't have the B antigen, it's fine. If somebody were to give you type B blood, your antibodies would quickly bind to them and destroy them. And then on the flip side, somebody with type B blood has anti-A antibodies. So if you gave them, if you took this red blood cell and put it into this person, their anti-A antibodies would bind to it and attack it. Okay, if you have AB blood, you don't have either of those. You have neither the anti-A nor the anti-B, so these are sometimes called the universal recipient, because they can receive either A or B blood. There's another layer to it, but on the surface, that's how it shakes out. Okay, so then if you have O blood, you have both anti-A and anti-B, so it's a little bit tricky to give O blood to, or it's really sort of tricky to give blood to O people, because they can only receive O blood. They can't receive A blood, they can't receive B blood, they can't receive AB blood, but they can receive O blood. Whereas if you have AB blood, they can receive all blood types because they don't have any antibodies. All right, now what's tricky about this is when we give people blood, we generally give them packed cells. So we'll take the blood, we spin it down, we take just the cells out of it, we turn the plasma back to the people, and then what gets put in the bag is just the red blood cells, not necessarily the plasma. If you grabbed a bag off the shelf that said whole blood, that would be a different story. That's got plasma in it. But if it's a blood bank or you're giving somebody a blood transfusion, it's just the packed cells. It's assumed that all of the plasma has to be returned. So all that you're really giving them is the red blood cells. And here's where we run into transfusion compatibilities. So think about this. Like if I took the A cells and I removed them out of the plasma, okay, this is all plasma stuff, and I asked, who can I give those red blood cells to? In other words, to whom can somebody with A blood give? Here would be the answer. They cannot give to AB, okay, because they have anti-A antibodies in their serum. Can they give to AB people? The answer is yes. And the way that you know is when you look at the antibodies in their plasma, they don't have any. So you could safely give type A blood to somebody with AB blood. And students always get confused by this because they go, well, wait a minute. Doesn't the person with A blood have anti-B antibodies? And if you give their blood to the AB person, the anti-B antibodies will attack the B antigen on their cell? Yes, but remember we're giving them packed cells. We're not giving them the whole blood. So the anti-B antibodies in their plasma, they stay in the donor. They don't get brought to the recipient. It would absolutely be the case that you could not give a whole blood to somebody with AB, but you could give A packed cells to somebody with AB blood, if that makes sense. Okay, and O's are tricky because they have both the anti-A and the anti-B, so you couldn't give them this cell, you couldn't give them this cell, or you could not give them this cell because they've got the anti-A and anti-B. All right, now there's another layer to this, and that is the RH factor, the RH antigen. This is also known as the D antigen, and it is what makes your blood positive or negative. Some blood types have, in addition, the RH antigen, or the D antigen, and other blood groups do not. What's interesting about these are not preformed antibodies, so somebody may or may not, or somebody, if somebody had a negative blood type, meaning let's say they were A negative, Somebody who is an A negative blood type does not have the Rh antigen. Somebody that has an A positive blood type does have the Rh antigen. So if you have an A negative blood type and you do not have the Rh antigen, it is not necessarily the case that you will have, like think back here, the people that had type A blood, they innately had the antibody that would bind to the blood type that was foreign to them. Well, if somebody has A negative blood, meaning they don't have the Rh, it's not the case that they're also going to have an anti-Rh antibody on here. That's what's different about the Rh antibodies. They actually they are conjured by an immune response. Generally, they're not just found here normally. So I've heard it said that you can give, especially for males, even if they have a negative blood type, you can give them positive blood because their body will attack the Rh antigen, and but so long as it's it takes a while for that immune response to occur. Like it might take a matter of days for that immune response to occur, and likely if you're giving them a blood transfusion, it's like an acute need where they need oxygen and they need blood right now. So even if they mounted an immune response in several days later against the Rh antigen that you gave them, likely the case by that point in time, they've already stabilized, they've already started making their own blood cells again, and they've got enough fluids and their blood pressure is intact where they could have that immune response, and your body could, their body could attack their blood cells, and but by that point they're already stable. Usually when you're giving somebody a blood transfusion, that's a really acute thing. You're trying to keep their blood pressure up so they can perfuse their head and get oxygen to it. And so all that to say, I've heard it said that you can give positive blood types to negative people, despite what you would think, in a pinch. Okay, that's what a student told me. I've never heard that from a medical professional. So now, where this gets to be a concern is this thing called hemolytic disease of the newborn. Okay, so this is something that it would be a concern if a mom who has a negative blood type is twice pregnant with a baby that has a positive blood type. That's where this is a concern, and here's why. The mom has a placenta, and baby's blood is kept separate from mom's blood. So this shows a little picture of the fetal blood. So this would be the baby's blood. What happens is when a baby is growing in the mother's womb, her blood or his blood comes in, and it becomes embedded in these sort of lakes of mom's blood, but it doesn't actually mix with the blood. It's just sort of like an exchanger, sort of like a fluid exchanger, and oxygen can come out, CO2 can come in, glucose and things can diffuse in all through diffusion, but they are kept totally separate, mom's blood and the fetal blood. You can see that if I zoom in here, there's a little space here. They're not actually physically touching. There's no physical mixing of mom's blood and baby's blood when mom is pregnant. So this shows then what would happen. This shows the infant's blood here. Here's a red blood cell. The baby has a positive blood type, so whether it be A positive, B positive, or AB positive. Okay, positive blood type. Generally, the blood is kept separate, so mom's blood is never going to come in contact with baby's blood, even though they become very closely associated. But on the first delivery of the baby, so when this baby is delivered, there's a lot of tearing that occurs, and the placenta can tear, and there can be some baby's blood that spills out, and the baby is born. So it's possible that some of the baby's blood can get into mom's blood at the first delivery when that baby is born. If that's the case, mom's going to have an immune response against that Rh antigen. The Rh antigen is foreign, and we always have immune responses to anything that is foreign to us. That's what protects us. So the Rh comes in, it's the first time mom's blood has seen it, and so she starts creating antibodies against it that can then bind and attack it. Now the baby's already born, so it's fine, but upon the second pregnancy, mom already has those antibodies now in her blood because she had an immune response which created these cells that make the anti-RH antibodies. Those cells stick around. They're called memory cells, so there'll always be some, now forever, some anti-RH antibodies in mom's serum. After a few months, the concentration of them will go way down, but there will always still be some memory cells there, probably secreting at low levels anti-RH antibodies. So now, if mom has a second pregnancy and the second baby is also Rh positive, now mom's antibodies, which are so small they can sneak across this barrier here, and antibodies can really get anywhere. They're so small and dissolved in the fluid, they just find their way into the very small nooks and crannies of the body. So antibodies, even though the red blood cells can't cross the placental maternal blood barrier, the antibodies can. And so during the second pregnancy, the antibodies would bind and attack the infant's red blood cells and probably ultimately kill the developing fetus or terminate the fetus. So to prevent that from happening, we can give a drug which is called RhoGAM. And RhoGAM is a synthetic Rh antibody. And we would give it right before the first delivery. So what happens is that the RhoGAM, right before delivery, you give the RhoGAM, and the RhoGAM goes in. You give it to mom, and it goes in and it destroys all of baby's red blood cells. Now, it's only going to destroy the red blood cells that are left behind after birth. If you gave RhoGAM really early on in the pregnancy, then it would be really harmful. But if you give it just right prior to delivery, then it's just protecting mom specifically against these red blood cells that are going to perhaps come in contact with her maternal blood supply. So in other words, it alleviates the need for mom to create her own immune response. And when we do it this way, synthetic antibodies, you give them and then they stick around in the circulation for a while and then they disappear. Okay, so then on the second pregnancy, there aren't these antibodies that are sitting around because of the immune response that happened, the memory cells that were made. The RhoGAM comes into the system and then it goes away, and we avoid the immune response altogether, so that on the second pregnancy there aren't these anti-Rh antibodies. These would only be hanging around here on the second pregnancy if mom had an immune response that activated their production on the first delivery. But with administering RhoGAM, it prevents that immune response from happening. You're basically giving mom passive immunity to something for a very short amount of time, and then that clears and it prevents the immune response. So a pretty clever mechanism there to prevent hemolytic disease in the newborn. Okay, just to wrap it up here at the end, we're talking about blood type. This is a great review table that you can work through, and I'll just do the first one for you, but I do highly recommend you work through it, okay? Antigens on the red blood cells. So somebody that has type A blood, type A minus, they would have A antigens. Somebody with A positive blood, they would have A antigens. They would also have the Rh factor. That's what makes it positive. The antibodies that they would have in their serum, they would have anti-B antibodies. And somebody with A positive blood, they'd have the anti-B. And while they might not have it innately, they could also have the anti-Rh made if they had an immune response. So we'll consider it, even though it's maybe not the case that's not there now. It could come later. Okay, so those would be the situations. Now when you ask yourself, you can ask yourself two different questions. To whom can you give this individual, or to whom can this individual give, or from whom can this individual receive? Those are two different questions. and they have different answers. So let's answer the first one. To whom can this individual give their blood? Well, they have the A antigen. So you would want to make sure that they're giving it to anybody that does not have the anti-A antibody in their serum. So you could give this to type A, and you could give it to somebody with type A minus or negative, positive or negative. You could give it to type AB, positive or negative, and that's about it. Type B, they're going to have the anti-A antibody. Type O, they're also going to have the anti-A antibody. Now, on this one here, you could give this to somebody with type A positive only and type AB positive only, because they also have the Rh antigen. And I don't think this is maybe how they do it in the clinic, as far as I'm told. In a quick situation, they will sometimes give positive blood to negative blood types. But for best practice sake, you would not want to give somebody with a you would not want to give a positive blood type to a negative blood type. You wouldn't want to give a positive blood type to a negative blood type. You can give a negative blood type to a positive blood type, but you can't give a positive to a negative. Okay, now on the other side, from whom can this individual receive? So when you think about from whom can they receive, you have to think about the antibodies that are in their serum protecting them. So you couldn't give them any blood type that has a B on it for the A negative. So you could give this, you could receive from type A, and you can receive from type O, but you can't receive from type B or type AB because they have the B, and you've got the anti-B antibodies. For the next one down, they are going to have anti-B and anti-Rh. So you could receive from I should maybe clarify here. You can receive from type A positive or type A negative, and type AB positive or type AB negative. Okay, the positive or the negative you can receive from. If you had, oh, sorry, that's, oh, you know what? I've got this backwards. My apologies. This wasn't confusing enough. I got this all backwards. This is anti-Rh here. Okay, so you could not receive from positive. You could receive from type A negative and type AB negative. Here you could receive the same, but it's type A positive or A negative, and type AB positive or negative. That looks better. Okay, somebody that has the anti-B and anti-Rh, you better not give them an Rh, and you better not give them a B. So you better not give them a positive, and you better not give them anything with a B in it. So I've already. So just to give you an illustration of how convoluted this is, I've been teaching this class for like 10 years now, and I still struggle with this. Okay, so make sure you're careful with this. You could receive from an O, you could not receive from an AB. You could give to an AB, but you can only receive from an O. Okay, I think this looks good. Now let me just double check here. You got an A antigen, and you got anti-B and anti-Rh. Good. You could give it to, if they have the A, you could give it to A positive or A negative, AB positive or A negative. Yep, that's good. And then you could receive from A or O minus or A positive, A minus. Yeah. Yep, that looks good. Okay, so that is a little bit tricky, isn't it? When you're asking to whom can you give the blood type, think about the A antigen on the donor's red blood cell and make sure that you're not giving it to somebody that would have the complementary antibody in their plasma. When you're thinking about from whom could you receive, you're not so much concerned about the antigen on the red blood cell, you're more concerned about the antibodies that you have in the plasma of the recipient. All right. So I would highly encourage you to work through this. I'll ask you a couple of questions like that on the exam, and you'll get a sense for, you'll be able to practice this to some extent on the homework quiz. To whom and from whom can different blood types receive? Those type of blood transfusion compatibility questions. There'll be a handful of them on the next exam. Okay, we're going to stop there in this riveting look into the nature of the blood.